Good morning, and thank you for joining us today for TPG webinar series. My name is Sarah Friend, and I will be the presenter on today's topic, the Oregon healthcare market. We're going to go ahead and get started. I see that we've got more people joining, but I think we'll go ahead and start right on time this morning. Since it's a Friday, I know you probably have busy days to get back to. We do plan on finishing up no later than 11 o'clock. And just a couple housekeeping items before we get started. All attendees will be on mute since we have such a large audience today. But I do want to encourage you to use the question box in the GoToWebinar toolbar on the right-hand side of your screen. This will help me capture your questions about the topics as we go through the information, and then that gives me a report that I can run so that we can respond to your questions via email to everyone who's registered for this webinar as a follow-up, so that you'll get the benefit of seeing others' questions and then receiving a group response in the next week. I'll also be sending out a copy of these slides to all participants. So feel free, you don't have to worry about taking screenshots. You will get a PDF copy of today's presentation so that you'll have it for your notes and you can share it with others in your office as you need. So just a quick introduction about this topic. I was asked to create this presentation for the Western Pension and Benefits Council after a breakfast meeting for their Portland chapter, and presented this information last week. You can see on the date on this slide, October 18th is when I first presented this to a live audience in downtown Portland. And it was such a great group discussion where we covered current events impacting both health insurance carriers and group and individual insurance purchasers. And we also talked about a number of topics related to forecasting what's ahead for insurance rates and trends for 2018 in Oregon. We got such good feedback from that session that we decided to go ahead and hit the repeat button and offer this topic as a webinar to the folks who didn't attend the Western Pension and Benefits Conference breakfast meeting. So it's a little bit unusual, though, for TPG to do a very state-specific webinar. We are a regional firm, as you know, and we typically cover topics that are not state-specific and, can serve all of our customers across the region and the nation. But in this case, because the information was specifically created for this Portland event, much of today's topics are going to be most interesting to those interested in what's specifically happening in Oregon. So if you're from Montana or Washington, there's going to be some information at the beginning of this webinar that's going to be, I think, pretty interesting to you, but then the rest of it gets into pretty state-specific information. So with that, let's go ahead and get started. So here's the agenda for today's webinar. We're going to start with headline news, and then we're going to go through a review of 2017, the Oregon health insurance carriers' financial statements, comparing how are they doing financially, 2016 compared to 2017. And then we're going to go through the Oregon health insurance, small and individual health insurance rate filings for 2018. So you can see kind of what's ahead in terms of what to expect for cost increases. We're also going to talk about trend factors and kind of averages of medical, pharmacy, dental, and vision trends that our carriers are using to create those 2018 rates for us. We're going to do a quick review of our carrier options in Oregon and how that compares with competition across the country. And then we'll switch gears and talk about, what's driving costs as we go into 2018, some future healthcare initiatives, and a little bit more about the Affordable Care Act. So let's start with headline news. I'm going to cover this in two ways. We're going to start with really what's happening at the federal level And many of you have probably, heard in the evening news and newspapers about this whole business of President Trump's executive order related to CSR payments. So I'm going to talk a little bit about what those are and why it matters here in Oregon. And then we'll shift gears and talk more locally about Oregon headline news, and specifically about that 1.5% premium tax that seems to be so controversial. So first, let's start off with headline news at the national level. So on October 12th, President Trump signed an executive order eliminating CSR payments. And CSR stands for cost sharing reduction. Those CSR payments were expected to total $9 billion in 2018. And when President Trump signed the executive order, a couple of statements came out from the White House. The first basically saying that the government cannot lawfully make the cost-sharing reduction payments, and that Congress needs to repeal and replace the disastrous Obamacare law and provide real relief to the American people. So what does all of this mean? Let's start with a quick review about what CSR payments are to begin with. So as many of you know, the Affordable Care Act provides tax credits to individuals with low and moderate incomes to help make health insurance premiums more affordable. There are really two ways that the ACA provides these subsidies for qualified families. The first is through premium subsidies. So that's basically just saying, we're going to help you reduce the amount of money that it costs you and your family to buy health insurance on the through the exchange marketplaces. And premium subsidies are available now in Oregon because we expanded Medicaid. Medicaid is available for families at or below 138% of the federal poverty level. And then these federal subsidies kick in for families with annual incomes between 138 and 400% of the federal poverty level. And in the next slide, I'm going to give you a table to remind you of kind of just where those income levels fall. Then these premium subsidies are, the monthly premium subsidies are calculated by taking the difference between the cost of coverage, and the cost of coverage is based on the second lowest cost silver plan available in the market, and affordability, which is based on a percentage of the individual's income. And basically covers the difference between what's deemed affordable for that family and the actual cost of coverage. Now, premium subsidies is what has received a lot of attention in the news. And so when we think about how the Affordable Care Act helps families, our brains go straight to these premium subsidies. But there's actually two subsidies in the law that helps low and moderate income families. The second is these cost-sharing reductions, or CSRs. And if you think about the cost of health care, it's not just the monthly premiums that we pay every month for coverage. We also have out-of-pocket expense when we go seek services from the doctor. And so CSR reductions were meant to lower deductibles for qualified families, lower copays, and lower out-of-pocket limits. These CSR reductions were only available if a family purchased a silver level exchange plan, and were only available to qualified families at or below 250% of the federal poverty level. Now, nearly 3/4 of exchange purchasers, or 6.8 million families, qualify for cost-sharing reduction payments. Go to the next slide. We'll just do a quick review of that federal poverty chart. So again, anything below 138% in Oregon qualifies a family for Medicaid. And then after 138%, then they kick over into being eligible to receive federal subsidies. So you can see that the federal poverty chart is all based on the size of a family. So anybody, that middle column, 250%. So families, let's take a family of 4, for example. A family of 4 with an annual income of $61,500 or below would be eligible to receive a CSR subsidy. So basically extra help in making sure that families' out-of-pocket expenses, in addition to their premium payments, remain affordable. So the CSR payments uncertainty and all this controversy around CSR payments are nothing new to at the federal level. We probably, most of it, haven't been following all of this controversy very closely unless you're an insurance carrier, and if that's the case, then you're very interested in the future of CSR payments. So the controversy actually started back in 2014. And in 2014, House Republicans sued the Obama administration, claiming that Congress never appropriated these CSR funds or the payments to the health insurance carriers that they needed in order to then reduce deductibles, copays, and out-of-pocket expenses for their members. And that the House Republicans, under their suit, claimed that the payments by the administration were unconstitutional and were an overreach. That lawsuit, went to court, and in 2016, a lower federal court actually agreed with the House Republicans that the administration had indeed circumvented the appropriation process and was unlawfully using unappropriated money to fund reimbursements due to insurers or health insurance carriers, and ordered the government to stop making CSR payments to carriers. But it did, knowing that the administration, or at the time, the Obama administration, would appeal this ruling, it did allow that the payments would continue during that appeal. Then in 2017, the spending bill that was passed continued to not include permanent appropriation for CSR payments. And then, obviously with a change in administration, we had a change in viewpoint, and the new administration, the Trump administration, did not want to continue the appeal and continue to push for these CSR payments to become lawful. And beginning in the summer, President Trump threatened to eliminate the CSR payments, and just a few weeks ago, the executive order was signed to stop, as of October 18th, the next week, any additional payments to insurance carriers to subsidize these reduced deductibles, out-of-pocket expenses, and copays. So this is just a letter the day before the executive order was signed by Jeff Sessions, basically, his opinion around the unconstitutional nature of these CSR payments. So why does this even matter? What is the impact to Oregonians? Well, it does impact mainly, it starts with insurance carriers, because insurance carriers are required to offer these lower deductibles, lower copays, lower out-of-pocket expenses to qualified families. And so to have, basically, they're on the hook for these payments without any subsidies coming in from the federal government. DCBS, which is the Department of Consumer and Business Services, which is the agency in Salem that governs, insurance in Oregon, they issued a statement the next day, so October 13th, where they basically stated that not to worry, nothing would change for Oregonians in 2017. And that, there wasn't going to be any change to plan designs to low and moderate income families, and there wasn't going to be any changes allowed to insurance premiums through the end of this year. But DCBS did go back to carriers and say, okay, carriers, you had previously filed your insurance rates for individuals, assuming that you are going to get these subsidies funded to you by the federal government. And now it looks like those subsidies aren't going to be flowing back to you. And for Oregon, for 2018, that amount of subsidy not flowing to Oregon health insurance carriers is almost $50 million, $49 million in projected CSR payments for Oregon carriers in 2018. So DCBS went out to the insurance carriers and said, we know you've already filed your individual rates for 2018, but we're going to open up the filing again for you to revise your rates so that you can cover this $49 million in projected CSR payment losses. So that resulted in carriers going back and refiling their individual health insurance rates for silver level plans that get these CSR payments. It was a 7.1% additional increase over and above what they'd already filed for 2018. So all the insurance carriers last week basically went in and refiled those rates. Now, prior to this executive order, the American Academy of Underwriters have been watching this very closely and kind of warned at the federal level that the elimination of these CSR subsidies to carriers would have potentially some unintended consequences of adverse selection, trouble to carriers, and weakened protections for individuals with pre-existing conditions. So what's interesting is, so plot twist, is that with this executive order, remember how I described the premium subsidies and how those are calculated at the individual level for qualified families with between 138% and 400% of the federal poverty level. Those are those monthly premium subsidies, not the CSRs, but the subsidies that help them keep their insurance rates affordable. Well, any increase in these silver level plans actually simply increases the amount of federal funds that those families will be receiving to help them pay for their health insurance. So this elimination of the CSR subsidy and resulting increase in cost of monthly premiums simply translates into an increase in the other federal subsidy that will actually increase the amount of money that families are receiving to help them offset that 7.1% increase. Because no matter how much the insurance rates increase, affordability is calculated based on a percentage of their income. So if those silver level plan rates go up, in this case by an additional 7.1%, for families who qualify for federal subsidies, it just means that the federal government will be offsetting that additional premium payment for families who qualify. Now, for families who don't qualify for federal subsidy, they will see that 7.1% increase, and they'll have to pay that full increase if they're on that silver level plan. But for families who qualify for the subsidies, the federal subsidy will offset the increase. So maybe an unintended consequence that in total, federal subsidies may actually increase overall through the amount that the federal government is paying in help to families may actually increase with this change. It's just which subsidy is getting more money. It may also shift enrollment because this increase in subsidies will decrease the cost of bronze level plans and decrease the incremental cost of buying up to gold medal plans. This may shift enrollment for 1/118 of individuals between medal plans. So are CSRs really dead? Most recently, you've likely heard in the evening news about this bipartisan deal between Senator Lamar Alexander and Senator Patty Murray to fund CSRs in exchange for giving states more flexibility within the Affordable Care Act. Trump has praised this bipartisan deal as a good short-term solution, and it also has the support of the National Association of Health Underwriters. So what's in the deal? The deal includes a 2-year subsidy for continued funding of CSRs, plus the balance of 2017. So basically, at this point, CSR payments are not being made to carriers. So in the event that this deal passed, it would shore up the rest of 2017 for health insurance carriers and fund CSR subsidies through 2019. It also creates a copper plan or a catastrophic plan for people older than age 30. Currently, copper plans are only available for kind of the young and invincible, so people under the age of 30. And then it also includes additional funds, restores funds. You may have heard in the news, you know, the cuts to funding of advertisements of the open enrollment period that's coming up for individuals, and cuts in funds for what are called navigators or insurance agents who help individuals shop for individual health plans. So it restores some payment to that. So can this deal get enough support, and how fast? You know, it's interesting. It does seem to be gaining some momentum and some support on both sides of the aisle, but it will be very interesting to watch to see if it can get enough Republican support in what may look like, you know, instead of repeal and replace, you know, an effort to kind of shore up the Affordable Care Act. So it'll be really interesting to see if this can get enough bipartisan support to pass. So we're continuing to watch this, and we'll keep folks informed on where this goes. So we just talked a lot about the individual marketplace, and most of the people are on the phone probably don't buy their health insurance in the individual marketplace. There is a spillover effect. So all of this uncertainty, this is actually a photo of a poor, you know, 35-year-old underwriter in Oregon, but you can see how the stress of all this uncertainty is creating some a lot of angst and anxiety for health insurance carriers. And all of that uncertainty around what's coming next, can we really count on, you know, the subsidies and things that we're expecting in order for our rates and, you know, what we are predicting our costs need to be for the future? Is that going to be enough? Can we count on the subsidies that we're expecting from the federal government? And all of this uncertainty about the current administration is adding a tremendous amount of stress on underwriters and actuaries, and you know, that uncertainty tends to lead to conservatism, and conservatism tends to lead to higher rates. And that not only affects just, you know, the individual plans that they're rating, but it does have a spillover effect, and that conservatism tends to spill over and affect the entire ecosystem of a carrier, how they approach group renewals, how they approach trend factors, which of course affects all of our renewal rates going forward. So while the Trump administrative order and CSRs may on the surface look like they have nothing to do with your group renewal, I would argue that there is, it does change kind of the overall atmosphere of an underwriting department's you know, level of optimism or level of uncertainty about the future. So what's next? If I knew, I promise I'd tell you, but I am in the same boat as everyone else, and you know, we are staying very close to all of these topics. At the Partners Group, we have our leaders who participate at both local and national, both PAHU and NAHU, and also CIAB. We have team members who go back to Washington, D.C., and we work through C2, our National Alliance of Independent Agencies across the country, to collaborate to ensure that we are up to speed and we're keeping all of our clients up to speed on what's happening and how it specifically affects your group health plans. So let's shift gears. We just talked a lot about what's happening at the national level. Let's talk a little bit about local headline news. So locally here in Oregon, the Oregon legislature, if you've already gotten your renewals, you're fully insured, if you're fully insured and you've already got that renewal, you've probably seen a new line on that renewal calculation. And it's the 1.5% premium tax. And that's the result of the Oregon legislature passing a $550 million healthcare tax plan that they said was necessary to prevent cuts in Medicaid. This new bill included a tax increase on hospitals and also a new tax on health insurance plans, which is that new 1.5% premium tax. The point of this bill was that lawmakers were attempting to close a $1.4 billion shortfall in the next 2-year budget to maintain current programs and services. Now, of course, there are people arguing on both sides of this. Democrats argued that without this tax increase, that there was a risk of eliminating coverage for 350,000 low-income Oregonians who are currently getting their health insurance through Medicaid. Now, in the event that we had a significant increase in the rate of uninsured in Oregon, that absolutely affects the group market. Because when we have uninsured folks in Oregon and they're going in for care that becomes unreimbursed to hospitals and healthcare providers, that cost shift is directly transferred to the group market in the form of increased rates of reimbursement that the hospitals and healthcare providers need to receive from their commercial book of insured Oregonians. So there is a direct correlation between the cost of group coverage and the rate of insureds in Oregon. So elimination of 350,000, insurance for 350,000 Oregonians would be a big deal for group health plans as well. So that was the argument for Democrats. And the Republicans argued that, yes, they didn't want 350,000 Oregonians to lose coverage either, but they argued that a much smaller tax could prevent this. So here's just a quick, slide of that budget hole. The majority of, the budget shortfall is really Medicaid, but there's some other components as well. So the budget shortfall is real, and it does need to be shored up. But the question is how, and what's the most appropriate means of doing it? Well, a Republican lawmaker in Oregon, was very opposed to this bill, and while it did pass, she spawned a petition that has now gathered enough signatures to put this new tax to a vote. So, Oregonians will see this on your ballot in January of 2018. And in the event that Oregonians say no to this new tax, then basically, we'll see what carriers do. They've already factored in the 1.5% premium tax into 2018 renewals. So in the event that this tax is shut down by Oregon voters, we'll just have to watch and see if that means, change or reductions in our fully insured premium rates, after the fact, or how that will be handled by carriers. The 1.5% premium tax does not apply to self-insured plans. So, this is a carrier tax that is passed straight from the carrier to the purchaser, but if you are a self-funded plan, of course, you wouldn't pay a state carrier tax. All right, let's shift gears and do a quick review on Oregon carrier financials. So what's the outlook for our health plans and how have they done financially? Well, we're going to start by going back a year ago and talking about financial positions by carrier in Q2 2016. And all of this information is available through the National Association of Insurance Commissioners. So this is straight from the carrier's filings. You can see that in 2016, there are 3 carriers on the far right: Oregon's Health Co-op, Lifewise of Oregon, and Health Republic, that are now no longer offering insurance in Oregon. And I'll talk more about why that's important in a moment. But those Lifewise will show up on the next slide because of some carryover into first quarter, but they'll show up in orange because they're no longer selling policies here in Oregon. So how do you read this chart? Well, a couple of important notes here is the incurred loss ratio, so that top line, really showing how much premium did the carrier bring in, and you can see this is data through Q2 2016. So basically, claims over premium. And it doesn't factor in the fact that, of course, the carriers need to cover their administrative expenses. So, everybody's running their incurred loss ratio through Q2 2016 was pretty higher, higher than it should be. And then if you go all the way to the bottom, underwriting gains and losses, you can see that many of the carriers had an underwriting loss in 2016 that is, not only not good for our carriers, but it is also, not good for purchasers for many reasons. One is, those losses are going to, translate into big needed increases that are paid by purchasers, whether you're a group or individual. And also, those losses over time, can weaken the financial security of the carrier. And we want robust competition in Oregon. We benefit from a healthy marketplace with lots of carriers competing in our state. And so when our carriers are healthy and do well, then that keeps costs down and keeps a really healthy competitive marketplace for purchasers. So let's compare 2016, so looking at that bottom row, underwriting gain and loss, compared to 2017. So you can see that in this case, the only carrier that as of Q2 2017 who had an underwriting loss in that period was Lifewise of Oregon. But we can kind of, discount that carrier because they've already exited the state. So other than Lifewise of Oregon, we've got a much healthier financial positions for all of our carriers in Q2 of 2017 compared to 2016. So hopefully that's a sign of more stability, and we won't see additional carriers leaving our marketplace. So let's switch gears and talk about our 2018 rate filings. So in Oregon, carriers are required to file their rates for both individual market and the small group market. The small group market is defined as less than 50. So we're going to start by talking about the individual market, which is the blue table on top. Excuse me, I lost my word there for just a second. The blue table on top. So you can see on the left each of the companies that have filed individual rates, and you can see the average rate request. So that was their initial rate filing that they submitted to DCBS, that percentage increase, then is translated to an illustrative rate that shows you what does that translate to a silver plan for a 40-year-old in Portland. So you can see comparatively where those rates are coming in for 2018. Then the third column is the preliminary rate decision. So DCBS, their underwriters, basically, this is true for small group and for individual. They take the insurance carrier's filings, they review them, and they say, do we think that do our underwriters agree with your underwriters? And do we think your rate filing is appropriate, meaning not too high and not too low? Because their role at DCBS is to protect both consumers by ensuring that the carriers don't ask for rates that are too high, but they're also protecting consumers by making sure carriers don't ask for rates that are too low that ultimately end up putting them in a financial position that they can't get out of, because DCBS wants to make sure that our carriers succeed and don't get to a point where they become insolvent. And so that's why you'll see in some cases the state has come back in their preliminary rate decisions with some cases rates that are significantly lower than the company asked for, and in some cases, especially in the small group market, you'll see that the preliminary rate decisions by DCBS actually ask carriers to increase the rates that they initially asked for, again, to protect the solvency of the carriers and ensure that carriers are in a great position to be able to pay claims for their insured members. So you can see there the final proposed rate decisions and the final proposed rates over on the right. The top box reflects those average rates for individual plans, and the purple table reflects the average rates for the small group market. For the small group market, we're seeing a couple carriers become much more competitive than they have been in the past. So it'll be interesting to see, how much movement there is in the market for small group health plans in Oregon beginning January 1, 2018. One caveat on the individual market is I pulled these filings off of the DCBS website before they had a chance to be increased by that 7.1%. So the final proposed rate decisions over on the right do not reflect the increase of, so you could basically add 7.1% onto the final proposed rate decisions, may not be exactly that, but it's about that, to know in the individual market for silver plans how much those rates are going to be changing for January 1, 2018. All right, let's shift gears and talk about trend. We've talked a lot about small group and individual rates, and those are rates that have to be filed with the state. But for medium-sized groups, so groups over 50, and at large groups, those rates are not filed with the state. But an important component that influences how much your group health plan rates are going to go up in 2018 is medical and pharmacy trend. So every year, the Partners Group, our analytics department, goes out to the marketplace and does a trend survey. So we ask our carrier partners to tell us, what are you using in your calculations of future rate increase renewals? What are you using for medical trend, pharmacy trend, et cetera? So you can see the carriers here are de-identified. So, we don't specifically tell you kind of whose trend is what. But you can see the average at the bottom of each row, the average trend for HMO, PPO, pharmacy, dental, and vision. The green average on the left represents the trends that were used in April 2016, and the blue on the right represents the most recent trend survey completed in April 2017. So you can see here that trends used in the calculation of medical renewals for 2018 for HMO plans have increased slightly from 6.65 on average to 7.42 this year. PPO has also increased by about 0.5%, going from 7.2 to 7.75. Pharmacy has decreased just slightly from 12.25 to the average of 11.3. Dental trends increased slightly, and vision stayed about the same. Trend is a really important component when you think about how your 2018 rates are going to be calculated. It basically is the underwriter's means of estimating if your health plan costs as a group were, let's say, $1 million last in the most recent 12 months. It's their means of predicting what that $1 million spend is going to be looking into the future. So it's taking the same block of people, the same block of experience, and saying, well, what is that same type of health care going to cost based on what we know about increases in utilization and increases in unit costs into the future. So it's generally a really important and an influential factor in how much you can expect your rates and how you can expect your rates to increase in the next year. So let's talk a little bit about what I talked about earlier, which is really wanting to ensure for Oregon that how do we maintain that healthy competition, and how does Oregon compare to the rest of the country? So here is a map of the United States, and this is a county-by-county analysis of the projected number of insurer participation in health insurance exchanges across the country. You can see that the counties in red are counties where there are no health insurance carriers available on the federal exchanges or the federal marketplaces for individuals. The yellow counties are all the counties across America that only have one option for health insurance. So if you're an individual buying health insurance on the federal marketplace, you only have one option. Then the shades of green, the lightest shade is 2 carriers, the medium shade of green, or that bright green, is 3 carriers, and the dark green is 3 or more carriers. So you can see in Oregon, we're pretty good. In most of our counties, we have at least 2, mostly 3, and in many of our more urban areas, 3 or more carrier options. That is not true across the United States, as you can see. So when we hear on the national news, the areas where, there's only one carrier option, I think we tend to think, oh, that doesn't seem right. And it's not for Oregon. We should be very proud of the fact that we have a pretty competitive and robust marketplace. We want to ensure that we continue that robust marketplace. Now for 2018, there are 3 counties where there was only one carrier that filed to offer plans in the marketplace, and DCBS, as I understand it, is currently negotiating with some additional carriers to try and get them back into the federal marketplace so that all counties in Oregon maintain at least 2 carrier options. So hopefully we won't have any yellow counties beginning in 2018. So we'll continue to watch and see how those negotiations fare at the state level with carriers. All right, let's shift gears a little bit more and talk about cost drivers. So leading cost drivers. So, when we think about, again, what causes our health insurance, whether you're an individual purchaser, small group purchaser, large self-insured, group, what are the leading cost drivers and why are our insurance rates escalating? The first component and the most important component is who is covered by that plan. So if you're a group of at least 100 covered subscribers in Oregon, for the most part, that plan is going to be what's called experience rated. So it means that the rates of that group plan are mostly, if not completely, determined by the composition of that particular risk pool. So it's not influenced by, the company down the street or across the county or on the other end of the state. That the cost of that company's health insurance is primarily driven by the composition of the risk pool of the people covered specifically by that group health plan. If you're a smaller group, less than 100 subscribers, then the smaller you are, the more likely it is that your group health insurance rates are going to be driven by a larger risk pool. So the composition of not only your business, but many businesses who are all mutualized into a much larger risk pool. But the health of that risk pool and the costs of that risk pool is the primary driver of health insurance costs. So, 80 cents of every dollar is driven specifically by who's covered and what the composition of that risk pool looks like. When we think about, break that down a little bit more and think about, well, inside the composition of that risk pool, what are a couple of the healthcare cost drivers that are standing out as unique as we go into 2018? And one of those is we're going to talk about a little bit about the significant increases in the cost of specialty medication, and then the increase that we're seeing in the marketplace in the frequency and severity of catastrophic medical claims, so those claims over $1 million. Now, healthcare costs, while that is who's covered, the health of the pool, and some leading healthcare cost drivers is the most significant cost driver. There are other components like administrative fees, taxes, et cetera, laws and regulations that also, of course, influence our 2018 rates. Let's peer into these two healthcare cost drivers that I've called out. So specialty medication, and then catastrophic medical claims. So first, this is just a really interesting slide, and this just, I think, illustrates some of, what we're seeing in the specialty drug arena. So, I'm not sure if some of you on the phone probably know about orphan drugs, and some may not be familiar with that term. I'll describe it in a minute, but I'll just go over this slide really quick. And there are 4 orphan drugs that currently cost more than $70,000 per month this year. There are 33 orphan drugs that cost at least $28,000 for each 30-day supply. So you can kind of see some of the names of the brand drugs and the cost per 30-day supply. So what are orphan drugs? Orphan drugs, I'll first talk about, the fact that most, pharmaceutical manufacturers, are incented to create medications that are going to appeal to the largest number of purchasers. And so there's a lot of, time and investment going into drugs that can serve, they can turn around, and once they've got a prescription that they can put on the market, you generally want to have a drug that you could sell to millions of people, not hundreds of people. So what happens is that these very rare diseases get very little attention from pharmaceutical manufacturers because it becomes very difficult for them to recover their R&D costs when they've, spent millions and millions of dollars researching a cure, but then can only turn around and that cure is only going to be, basically sold to a couple hundred patients a year. So in order to incent pharmaceutical manufacturers to not leave out these individuals who are suffering from rare diseases out of the equation, then, there's a law that basically relieved some, cost limit pressures to say, okay, you can charge, significantly more for these medications in order to hopefully, recover some of your R&D expenses. Well, there's some controversy now at the national level that said, well, this well-intentioned law around orphan drug pricing that was intended to encourage research and development dollars and attention on these very severe and rare diseases was well-intentioned. Is it getting abused by some pharmaceutical manufacturers that are trying to get their drugs listed as orphan drugs simply so that they can charge significantly more for their treatments? So there's a really interesting kind of national debate going on around these drugs. Now, I am not an expert. I have no way of looking at these drug names and saying, okay, which are legitimate, orphan drugs under the spirit of the law and which are kind of, abusing the law. But from a cost perspective, it's very interesting that we are starting to see these medications that, could reach $1 million a year in treatment. Another, unusual spike or trend that we've been seeing outside of, specialty medications is this increase in the frequency and severity of $1 million claims. So, this shows the increase since 2013 of the percentage of claims in each bracket there, so 1 to 1.5 million, 1.5 to 2 million, 2 to 3 million, and $3 million plus claims. And then a total overall increase of more than 60% of $1 million or catastrophic claims since 2013. Now, some argue that this increase in $1 million claims is an unintended consequence of the elimination of the lifetime caps under the Affordable Care Act. Now, that is not to say at all that the elimination of lifetime caps was a bad thing. I think most people agree that the elimination of lifetime caps is a good thing. But even good things have unintended consequences, and once we saw those caps being eliminated in terms of how much insurance carriers would pay for an individual's claims, all of a sudden we saw, a pretty significant increase in the spike of claims that all of a sudden exceeded $1 million. Of course, when insurance, capped at $1 million, providers, it was very unlikely that they would see any reimbursement beyond $1 million because you're not going to get that level of reimbursement from families. So once that cap was removed, we have seen a significant increase in activity around these large claims. And large claim activity has a very significant impact on a group's experience. So if you see large swings and large increases year over year from both a large individual employer and from an overall risk pool, it's generally related to a pretty significant increase in catastrophic claim activity. So in our last 5 minutes, I'm gonna shift gears a little bit and not talk so specifically about what to expect in 2018 and what's happening, that viewpoint, but talk more holistically about a couple of trends that we're seeing get a lot of activity with our local carriers. So one is, and this is just a really interesting article, I would encourage you to look for it, it was in the New York Times. It was an article written by a doctor. It was printed in just last month, September 28th. It's called The High Price of Failing America's Costliest Patients. And it's just a really interesting view about, that ultimately, if you talk to, the people that we serve individually, if you're a group purchaser, your employees, their family members, and you talk to, the folks who have the highest health care needs, that it's not health care that they want, that they ultimately want improved overall health. And so, this doctor kind of laments in this opinion article that he writes that, people generally, even if he's got a great bedside manner, people generally aren't happy to see him. They would rather have their health than to, come in and have to visit him every week for the treatment of their chronic conditions. So he talks a lot about how can we shift from this economy of unit-based pricing to value-based care. And we're really seeing, that changing provider payment model. It's going to take a long time for our carriers to continue to make progress in this area. But we're encouraged with the programs that we're seeing at shifting from the old paradigm of, paying strictly on volume of care to really working towards a payment model that aligns reimbursement with good overall health outcomes and incents shared decision-making between patients and their physicians and makes investments in practice transformation that allows better communication between our hospital systems and healthcare providers. So, again, we're going to have to take incremental baby steps as a state to get to where we want to go from a provider payment model. But we are encouraged. We've got a couple really progressive carriers in our state who are really, trying to push this forward, and that is encouraging to watch. All of those efforts really are intended to put the employee, the ultimate member subscriber, at the center of the healthcare equation and focus more on wellness and prevention, which we know so many of our employers are really working to create more robust and meaningful wellness programs that are tied to more closely with their health claims utilization. So working with Alexa Galuzzo here at our office through Partner Well and looking at their health data through Interis to really partner with our carriers to come up with those programs that are focused on wellness and prevention. And then the carriers working with providers directly on payment models that support personalized care coordination and provide providers patient-specific data to improve their health outcomes. So with that, we are right on time, and I hope that this has been a good hour of information, just giving you kind of a highlight in terms of what to expect in 2018. Hopefully it's given you a little bit more context as you listen to the news and watch all the debate around these CSR payments, and as you see in our ballot box or in our mail for January, that vote on the 1.5% premium tax, and gives you a little bit more context about what's going on. Again, please use the question box on the right to let me know if you have additional questions. I'd also love to hear from you if you've got other topics that you're interested in. We really enjoy providing these webinar educational series to our clients and customers. So if there's other topics you'd like us to bring you information on, let us know, and we'll be happy to prepare that for you. Thanks so much.